Good evening, everyone. Thank you for joining us tonight for session 3 in our Chrysalis Wellbeing series. So tonight's topic is older person's mental health. My name is Charles Broadfoot and I'm one of the Professional Development Officers with the Primary Health Network. And I'd firstly like to acknowledge the First Peoples and traditional custodians of the lands in which we're all meeting tonight. I'd also like to pay my respects to elders past, present and emerging. So tonight's session is being recorded and the recording and the slides will become available from tomorrow on our PHN website. So to access these, just head to our website, thephn.com.au, and click on the Education tab. So tonight, like our other live streams, we'll be using Slido. So we'll be using Slido for the questions and also the session evaluation today. So you can access Slido on the right-hand side of your screen. So you'll see there's a polls and a Q&A tab. Alternatively, you can head to slido.com, that's SLIDO, and enter the event code CWS and the number 3. So that stands for Chrysalis Wellbeing Session and then the number 3. And a third option is scanning the QR code, which will pop up on your screen throughout tonight as well. So please type your questions in throughout. We will have some time throughout the presentation to answer a couple of questions, but we also have blocked off some time right at the end to have a panel discussion. So that's enough from me. It's now my pleasure to hand over to tonight's chair. So we have Dr. James Woolstenholme. James is a GP who lives and works in the Central Coast. James works at Mingara Medical Centre and he's joining us tonight remotely. So thanks, James. I'll hand over to you.
Thank you, Charles, and good evening, everyone. Welcome to what I hope will be a helpful and informative session about mental health issues in later life. I'm pleased to introduce with us this evening, we have Dr. Petra Muir, who is a senior staff psychiatrist working in the Hunter, New England area, and Dr. Robin Freed, a general practitioner who's worked in Lake Macquarie for the past 20 years, and also Sandra Fitzgerald, who's the Health Pathways clinical editor. The format is going to be, I'll hand over to Dr. Muir shortly for an educational session, and then there'll be a couple of case presentations presented by myself and Dr. Freed, and then a session on the health pathways, which Sandra will do after that. And then we'll have some time for questions, but we will slip in a few questions along the way if they're particularly relevant to the presentation that's just finished. So I'd like to hand over to Dr. Muir first for her presentation, please. Thank you very much.
Thank you, everybody, and good evening, and thank you for joining us tonight. I also would like to acknowledge the traditional custodians of the land on which we're working and pay my respects to elders past, present and emerging. Now, tonight we'll be talking about depression in older people. I'm a psychiatrist working in the older person's mental health team in Hunter, New England, and I've got quite a lot of slides, some of which are quite busy, so we'll get started quite quickly. Don't worry if I gloss over a few things because this will all be available on the website and not all of this information was meant to be dealt with in detail tonight. First of all, I'd like to look at the burden of illness, which is quite high for depression, and World Health Organization quotes the years lived with disability as 7.5% for all ages. So this applies to older people as well as younger people. So depression remains the single most important predictor of suicide in older people and increases both risk of hospitalisation and healthcare costs. It adds to disability and poor recovery from comorbid illness, particularly relevant in our older population, and is an independent predictor of mortality of all causes, not just suicide. Okay, so what do we know about the epidemiology? Certainly the prevalence in the general community of major depressive syndromes consistent with meeting Dsm criteria is relatively low, 4%. However, it's important to note that that figure underscores the fact that depression isn't a given as we age. It's not a normal part of ageing. However, it's an important syndrome we need to address. And over and above that major depressive syndrome, we also have a number of sub-threshold depressive syndromes which present frequently for treatment and benefit from treatment. The prevalence varies considerably in different settings. In aged care, we have figures ranging from 5 to 25%, and these are in Australia but reflected also internationally. Depression in Alzheimer's disease occurs in up to 50%. Post-stroke depression is also at a fairly high rate, And we see that post-myocardial infarct, depression contributes to increased mortality. Males over 85 are at the highest risk of death from deliberate self-harm at 33 per 100,000 population. And we have seen a little bit of a drop a few years ago in the death rate in the slightly younger age group, 75 to 79, but it's creeping up again recently. The good news, however, is that treatment response rate in those over 65 is excellent and is reported to be as high as 90% if adequate treatment is utilised. Okay, I like this little lunic because it shows 4 people, one of whom is reading the paper saying, "You people really should keep up with the news. It says here that 1 in 4 people suffer from depression." And noticeably, the poor soul who is aware of that is the one sitting there looking very depressed. Interestingly, and this is a telling comment, I think, by Lunic, the 3 people that are looking happy are engaged in activities, socially active and pleasurable activities, which I think is a really critical point here. So what about the etiology and risk factors for depression? Certainly we know that age-related stressors exist, and there's a long list of them. Most of them won't surprise you. Social isolation, move to institutional care and elder abuse are 3 that are particularly relevant to older people. And loss of a close network, friend or relative, not necessarily a spouse or partner, has been recently identified as another significant factor or marker for depression. Other risk factors include a range of things, quite a broad range of issues. Adverse childhood experiences are now coming up as being significant. Physical illness of a variety of types, and particularly Parkinson's disease, stroke. I'd like to note obstructive sleep apnea because it's one we don't always think about. We recognise its role in cognitive changes, but it certainly has a significant association with depression. Cancer, not just paraneoplastic syndrome, but even outside of that, and severe and chronic pain. Alcohol, dementia, autism spectrum disorder is one that's now coming up as being interesting in its association, and sleep disorders, which confer a 1.5-fold increased risk of depression. So a number of studies, which I won't go into all the details, but specifically there's a significant association between elder abuse, total financial dependence, lack of social support and depression in elderly patients. And adverse childhood experiences, we've got some really good data from the US CDC's Behavioural Risk Factor Surveillance Survey from 2010, which looked at a large enough sample of 8,000 or more adults aged 60 and over. They didn't really have, they had a Caucasian prevalence, I think, which means that it's difficult to generalise to other cultures, but nevertheless, 6 different types of childhood adversity were noted, and each of them were significantly correlated with depression, providing they were repeated. So a repeated experience of this was significantly correlated. Interestingly and a bit disappointingly, they didn't look at neglect or emotional abuse, because my personal experience is that patients report this quite frequently when I see them, with depression, and I have somehow managed to fast forward too far. Okay, autism spectrum disorder. There was a good study in the Netherlands in 2016. 31% showed elevated characteristics of ASD in the depression group versus 6% in the comparison group. And interestingly and importantly, ASD characteristics were also associated much more with anxiety disorders. Advanced cancer. Somehow I think I better stop touching that clicker. Advanced cancer is also correlated with depression, and the prevalence was found to be 67.4%, doubled or more than doubled if metastatic disease was present, and more than tripled if there was comorbid cognitive impairment. So in that study, in the cancer study, strong independent predictors were pain, decreased physical activity, so even people who had been able to just walk a little bit and no longer could, sadness, reduced social activity and reduced enjoyment in life. Okay, so this is just a diagram which leads us to look at how depression can contribute to dementia. And we see here that genetic factors and childhood trauma and stress converge upon depression. In older people, genetic factors are less relevant if the depression is a late onset depression, so first onset in old age. Bidirectional effect is of note because depression can lead to the pro-inflammatory cytokines centrally, and in reverse, that can lead to depression. All of these have their pathways to apoptosis of both astrocytes and neurons, and then eventually impaired neural function and dementia. Okay, just quickly a summary of the pathophysiology of depression. Neurotransmitter theories, they're probably the ones we're all most familiar with, relating to the development of most of our medications. Again, causal factors leading to vulnerability, psychosocial adversity, and then specific mechanisms which mediate depression occur via both hypermetabolism of the dorsal neocortical structures and hypermetabolism of ventral limbic structures. This is a very nice summary in terms of a PET scan where the patient's brain on the left is that of a depressed patient and on the right a not depressed patient. The not depressed patient lights up normally on the PET scan with the lovely bright yellow areas, which are very limited in the depressed patient, indicating quite clearly that depression has significant functional impacts for neurological function. Okay, so this is a rather simple diagram outlining the major domains of effect of each of the three main neurotransmitters involved in depression. There are others, but these are the three that we focus on most heavily at the moment. It's not really as simple as this suggests, because each of these transmitters has effects at several regions and different efferent effects. The main message, however, is that we do need to review the effectiveness in every person and be ready to respond with either dose titration or change in antidepressant to a different class, because each of these has different functions. Interestingly, dopamine mediates reward, motivation and pleasure. Norepinephrine, noradrenaline, I'm going to say because it's easier, memory retrieval and arousal, and that fight or flight panic feeling, and serotonin, a feeling of well-being and relaxation, and probably is very relevant in anxiety. Okay, so this is a busy slide, and I'm actually going to go through that fairly quickly. Dsm criteria under DSM-5 haven't changed a great deal since DSM-4 TR, but notice the rigidity in the timing. We need to consider that it has to be for a 2-week or longer period that people have symptoms, and that's really to ask us to think about adjustment disorder and grief as differential diagnoses in the early stages when people present with depressed symptoms. I want to note anhedonia, which is the second point there, diminished interest or pleasure. And here we really have to define what is a true lack of interest or joy. We need to exclude an inability to participate in activities purely because of lack of access due to disability, pain or other social determinants. So when someone says to you that they're not enjoying life, it may not be true anhedonia. It may be that things that they normally would have available to them are not. So you really have to nail that one tightly to meet that criterion, and it is important. Weight loss is a bit of a misleading characteristic in older people because we have comorbid physical factors which affect appetite and weight. Fatigue can also be difficult to determine causality because of chronic illness. However, it can help if you try to define details such as the type of activity which causes fatigue and any change from their usual baseline prior to the drop in their mood. So both fatigue and weight loss can be unreliable. Thoughts about worthlessness, guilt, hopelessness, helplessness, they seem to be the more cognitively based rather than physically based features, and they are the more helpful when you're trying to establish depression in an older person. Recurrent thoughts of death or suicide need to be addressed carefully, and I generally like to start fairly gently and ask about passive feelings. So questions like, is life not worth living, or do you feel sometimes you don't want to wake up? And that's a gentle way to introduce the subject. And then you can move on to ask about plans of suicide, looking at details of methods considered, and then explore the seriousness of this. You know, how important is this to you? What have you tried? Are they collecting medications? Have they got access to weapons? Have they thought about it in more detail? And finally, protective factors. If the patient can't identify any protective factors, any reasons why they're not going to kill themselves, then that is of some concern. And I think if they can identify them, then you can utilise that in a positive way to reinforce optimism and something to hope for and look forward to. It's also worth monitoring those protective factors, because if they do change, if someone significant dies or a pet dies or has to be taken away because they go into aged care, those protective factors are then gone and you need to be aware that they're at more risk. Okay, next slide. So there are a number of other criteria here. Substance abuse criteria is again a difficult one. It doesn't necessarily exclude a diagnosis of depression. The timeline of onset of symptoms can be helpful, but I think you need to be aware that comorbid alcohol use and other substance use may be present in those with depression. And in older people now, I'm seeing quite a lot of people come through with THC or cannabis abuse, certainly the usual prescribed opiate and benzodiazepine use, and occasionally now we're also seeing illicit opiates, amphetamine and cocaine use. So it's worth asking about those things, and particularly stimulants, because when they don't take them, if they have a break or stop them for a few days, you can certainly get depression as a result of that. Now, medical conditions are meant to be excluded as a primary cause, but medical comorbidity is the rule in the elderly, and physical factors need to be sought out and treated. However, if you identify something potentially medical that may be contributing, don't delay treatment with an antidepressant just on those grounds, because I think you may need to wait quite a long time for depression to remit, say if you adjust thyroid medications or remove some medication that might be contributing. It could still take some weeks to months to abate. So starting treatment early is important. Anxiety is an important predictor for prognosis. It's certainly a prognostic factor for both suicide and difficult to treat depression. This is just a nice little slide that I think is useful as a tool for talking to patients about depression. It separates out the affective components, the emotional, the cognitive and the physical, and lists some common symptoms that they might be familiar with, helping them to understand that, what is actually part of their illness, and reinforcing the fact that this is a treatable condition. Okay, so clinical features, the ones that I have highlighted here are the ones that we see relatively more frequently in older people. Although there's not any clear objective evidence to say that there is a different phenomenological syndrome in older people to younger adults, we do tend to see more psychomotor agitation, more helplessness as a cognitive construct, more cognitive complaints, and a somatic preoccupation. Okay, the other factors we can talk about a bit later, but delusions are relevant to think about. Are they mood congruent? Do they actually have a very negative flavour to them? Are they nihilistic? Are they somatic? Because these are the types of delusions we most often see in depression. And melancholia is a condition which takes into account certain subfactors of depression, such as weight loss, poor appetite, early morning awakening and diurnal mood variation, and often marks a more difficult to treat and serious depression. Catatonia is a serious syndrome often associated with motor disturbance and mutism, and sometimes refusal to eat and drink, so it requires more urgent treatment. Now, there are a number of useful screening tools that have been validated in older people, and I won't go into details here. That I've included 3 of these in the appendices for you to have a closer look at. The Geriatric Depression Scale, 15-item version, is a useful one. It doesn't take long to administer, and it has good cross-cultural validity. It's not valid in severe dementia, so in that case I'd go to the Cornell scale, which has a mixed observation and informant components. That takes a bit longer, 30 minutes, but that's one you might think about using if someone's in a nursing home. The Geriatric Suicide Ideation Scale, unfortunately, was developed in Canada, and I think it's still under copyright, so I'm not able to provide that for you. But it's felt to be useful for community-dwelling individuals, and it specifically looks at factors related to suicide. And the Hospital Anxiety and Depression Scale is also very useful. It actually has 2 sets of scoring, one for anxiety, one for depression, which is useful, although I would caution you not to see those 2 as separate diagnoses in all cases, because the way I conceive of this is that they end up being 2 sides of the same coin. We use treatments very similar treatments to treat anxiety and depression, and considering something as an anxiety disorder and not looking at antidepressant management can actually deprive someone of adequate, timely treatment. So, depression and physical illness, this is a two-way street. Depression clearly is a risk factor for a number of physical illnesses, including stroke, cardiac mortality, possibly cancer. It increases disability, certainly impairs rehabilitation in the severe stages, can worsen prognosis post-infarct. The depression risk is doubled if someone has diabetes. The lifetime prevalence is actually 75% in those with diabetes mellitus. And notably, the actual prognosis for depression and both diabetes are worsened when they coexist. Sorry, here we go again. Disability is a risk factor for depression. Chronic illness impairs prognosis in depression. So you can see that the bidirectional effects are quite profound. And the only way to get out of this two-way street or closed loop really is to provide optimal treatment for both depression and physical illness where possible. Okay. Quick discussion on depression and suicide. The gender paradox is interesting. Females have more suicidal ideation than males, and males have a higher risk of completed suicide. This is not just for older people. I think this is across all ages, but we do also see it in older people. And I wanted to note that the risk factors here are all relevant, particularly anxiety, insomnia, and past history of attempted suicide or self-harm. That's something that needs to be carefully noted. So if you're concerned about someone's suicide risk, ask about the past. And self-neglect, not to forget, may also be a de facto means of suicide. So people who stop taking their medications, who stop going out, who stop exercising, who don't have showers, who don't eat and drink, may have made a decision that, you know, they're not going to, they don't want to live, so they're not going to do anything. Okay. And this is Australian Bureau of Statistics graph looking at the age-specific death rates for intentional self-harm by gender, and this was from 2018. And as you can clearly see, the males are in blue, the females are in brown. The males outstrip the females in every age group, but in the over 85s we have the highest death rate of all, and in the over 60s we have a considerably high death rate from suicide, so it's important to recognise the risk there. So, what are some of the things that might be barriers to recognition and appropriate treatment? Frequent comorbidity of anxiety. Severity may be underestimated in the frail oldest old due to physical factors which look like depression. Physical comorbidities are excluded from a lot of epidemiological studies, and physical illness may mask symptoms. Almost half of those with depression receive potentially inappropriate drug treatment with anxiolytics or hypnotics in one Swedish study reported in the American Journal of Geriatric Psychiatry in 2016. That's 50%. So anxiolytics or hypnotics involve the benzodiazepines and the so-called Z drugs, which really should be avoided in depression. Okay, aims of treatment. Look, if possible, remission of all symptoms, but it's worth saying that sometimes we know that it is difficult to treat, and it's important to target those symptoms which are causing the most distress, and certainly anxiety and suicide, anxiety and insomnia, which contribute to suicide risk. Okay. Now, there was an interesting study on prevention in primary care, also reported in the American Journal of Geriatric Psychiatry in 2011. They included patients with subclinical symptoms, so we're not just looking at DSM major depression here, and they were randomised to a prevention therapy group and a treatment as usual group. And prevention therapy consisted of watchful waiting, minimal supportive CBT, problem-solving strategies, and medication when required. So none of these are really intensive treatments, but at 1 year follow-up, the cumulative incidence of depression could be reduced by 50%, as was reported here, and the number needed to treat was quite low, only 5. So it's worth thinking about that sort of intervention process, and the argument there is to screen carefully for depression in primary care and try to treat it early. Acute treatment phase, usually weeks to months, where we aim to attain remission. A continuation phase, we look at preventing relapse. Importantly, if this is the first episode, then you can consider tapering at the earliest at 1 year. If it's the second episode, lifelong, it's recommended you continue for up to 2 years before you taper the antidepressant. So longish periods of treatment. For those who have had greater than 3 episodes, you may need a maintenance phase to look at preventing recurrence. So it's very important to avoid suspending treatment too soon, and maintenance phase might be indefinite. Okay, again a Leunig, and this one is really Leunig encouraging us to consider, to be mindful of who benefits from overly simplified prescribing practices. What have I done? Here we go. So depression is nothing more than a simple chemical imbalance in the brain, says the doctor, and he's going to send the person away with a nice little pill which soon will give a pleasant sense of confidence, control and normality. The patient looks a bit dubious and says, "Thank you, I'm so grateful, you're so marvellous." And in the end, the one who looks the happiest about all of this is the clinician. And really, it's what we all hope to do, something simple, something easy, but mindfully, we don't always achieve that for the patient with medications alone. So the treatment approach needs to be multimodal, multidisciplinary, involve risk assessment and monitoring, which is very important. Starting an antidepressant is just step one. We really need to continue and review regularly. Treat comorbid physical illness. Engage the patient and the carers in education and buy-in into what's happening, because one of the biggest problems we have is medication non-adherence, particularly in the early stages due to side effects. Look at other ways of minimising disability, certainly trying to remove barriers to social activity and physical ability. Review and cease inappropriate medication, and deprescribing is a really important component here. Looking at social issues and initiate appropriate antidepressant and or psychotherapy. And the levels of evidence here are quite clear. Antidepressants, ECT and psychological treatments all have level 1A evidence for them. Psychodynamic therapy surprisingly also has level 1B evidence, and problem solving and self-help 2B. Everything has some benefit on this page, but a meta-analysis, 2008, said that psychotherapy is efficacious and comparable or superior to drug therapy. So it's worth bearing that in mind. And I lost my slide. Okay, so I'll skip over this one, matching type and treatment. You can have a bit of a look at that later, and I'll certainly skip over that. It's a busy slide looking at the neurotransmitter theories. I've got a bit of a red light system here for a guideline for antidepressants, and things have changed a little bit. We certainly look at the red light antidepressants as those that you would want to avoid or keep as low as possible. And now this is really a principle for initiating treatment. Sometimes patients will come to you on these medications, and then you have to think very carefully about their past history and why they're on them. Has there been a series of trials of treatment, which means they only responded to a tricyclic, and you might need to consider continuing that. So, but for first initiation, it's not first-line treatment. SSRIs, SNRIs, and the NASA group are probably the best ones. However, even within those subgroups, we have concerns. So citalopram, escitalopram, very high risk of QT prolongation in our older people. So if they've got cardiac disease, best avoid. Fluoxetine has a long half-life, and so we're not really keen on using that, because if you use that as a first treatment, then getting them off it and washing out to another antidepressant can take weeks. Paroxetine has a very short half-life and has a lot of receptor effects and side effects and interactions with other drugs, so we tend to avoid that. Mirtazapine is a good one. We don't use the stimulants, although younger people do. There are some atypical treatments that are worth considering: agomelatine, bupropion and vortioxetine, but with some caveats and caution. Agomelatine has serious hepatotoxicity as a problem, so we do like to do baseline liver function and monitor that. Okay, so again, the major factors to consider in treatment are age-related pharmacokinetics, specific symptom targeting, previous response to treatment, and that's worth really looking at closely, tolerability, safety, the adverse effect profile based on their physical comorbidities, drug interactions, medication adherence, and their psychiatric comorbidities. So if there's anxiety, obviously SSRIs seem to be a better group to use, psychosis, we need antipsychotics, etc. And so this is a slide which kind of summarises which antidepressant is best if you also have various considerations or issues. So it's a busy slide and I'm not sure how much time I've got left, so I might just skip over that. A note about treatment in the very old, which is important because we often worry about those over 80. Baseline antidepressant treatment doesn't seem to be independently associated with increased mortality risk, so we should encourage use. Possible errors, I think, when you're treating people for depression include not removing benzodiazepines. They actually have a depressant effect, so they generally affect the GABAergic system centrally, and that tends to oppose the effect of our antidepressants. They also have a lot of side effects which are inadvisable, increased risk of falls and cognitive impairment. It's also worth noting to do baseline bloods and particularly check for sodium and renal function because this might impact your decision on which antidepressant to use. Checking vitamin D is something that we're doing increasingly now because vitamin D deficiency has been associated clearly with depression and suicidal thoughts. And most importantly, review effectiveness. I would recommend generally weeks 2, 4 and 8. Week 2 seems early, but this is where you'll pick up the people who don't adhere to medications. And non-adherence is particularly a problem with cognitive impairment and early adverse effects. Avoid rapid dose escalation, avoid starting too high. So the old start low, go slow is relevant. Lithium, I've given a separate slide to because I've seen a number of concerning situations with lithium. It has excellent efficacy in depression, but a high potential for morbidity and mortality. So you really need to check levels regularly, and sooner if you're concerned about symptoms. You have to advise the patient and you have to monitor their hydration status to minimise risk of toxicity and renal impairment, and use diuretics with caution. So education of the patient about prevention and signs and symptoms of toxicity is important, and be aware that you can have acute and chronic toxicity which can occur separately or together. And acute toxicity can escalate over a few days, so if you're checking lithium levels 2 to 3 monthly, you could miss that, and so education is really important. And I've just listed the signs and symptoms there. Now, this is not a slide to tell us we're going to finish and have a cup of tea now. It's to remind me that there was an interesting study in Singapore looking at the benefit of camellia census. And it actually did show, it was a 2-year follow-up study, some important benefits and a reduction in association of depression in those who drank progressively more cups of tea a day. And they looked at 1 up till 5 or 6. Other emerging treatments, I can quickly mention subcutaneous ketamine. There was a pilot study done in Australia. The sample size was small. There were a lot of methodological problems there. Clearly it's not currently approved by the TGA, so off-label use only. It's very short-term in its effectiveness and rebound can occur, and our college noted significant gaps in knowledge and long-term safety particularly. There's a new format, S-ketamine nasal spray, which has been developed and is in use overseas but not yet available in Australia. Once again, there would be similar cautionary messages with regard to that, particularly in terms of cardiac risk. Other treatments listed here are all still experimental. And magnetic seizure therapy is different to transcranial magnetic stimulation. It's actually a magnetic induction of a seizure. So that brings me to neurostimulation that we do use, which is ECT, which is the most effective of all the treatments we have. 80% response rate. It's a first-line option if you have psychotic depression. It's effective and safe in our very old. And it's also effective in depression and dementia, but we have a higher risk of delirium, so we tend to avoid it if possible. It has a rapid onset of benefit, so it's preferred in urgent scenarios such as suicide risk, catatonia, etc. As for TMS, there's limited evidence for its benefit in older people with moderate to severe depression. There may be some emerging evidence of benefit in mild depression. It's expensive in Australia, at least in our area. It's not available in the public system, or it may just be beginning, but generally speaking, the private system costs about $9,000 for a treatment episode. Prognostic studies indicate that with adequate treatment, these are in hospital studies, 60% of people with depression remained well or had treatable relapses, which is really quite good. 15 to 20% developed some chronic symptoms, but the majority of these remained well or had treatable relapses. Community studies had a less good outcome, And predictably, this is probably related to the use of treatment. In 3 studies, the use of antidepressants noted that only very low percentages of people with depression were treated with antidepressants. Okay. So, not sure if we have time for questions. We might save them for later. Just note, I've just got the scales there in the appendices and some references for you. Okay, how are we going for time? Okay, so I'd like to hand over to my colleague James, who's a general practitioner in the Central Coast, for his case presentation. Thank you.
Thank you very much, Dr. Muir, for that very comprehensive overview. Certainly a lot of interesting stuff there and things that are going to be very relevant to my management of depression in elderly care. And if I could have my presentation up, please. My presentation is going to focus on the aged care facility situation. And the particular challenges that represents. There'll be some overlap with what Dr. Muir has covered, so we'll skip over some of that. But I'd like to tell you about this case, which I think is interesting. So this is a 78-year-old man who has quite a complex background. Pre-morbidly, he was a self-employed bookmaker with a strong interest in sports. He's very interested in rugby, football, and other sports. Married with 3 children, had a history of intermittent depression in the past, with possible bipolar episodes, although he had never been formally diagnosed. But his major health event, unfortunately, in 2010, he suffered a very dense left-sided hemiplegia, following which he had seizures and some mild cognitive impairment. And he became significantly disabled as a result of this. His left side did not recover, and he started to require fairly high-level care. He also has a history of chronic pain, which primarily relates to a degenerative shoulder and an arthritic ankle. And he has a family history of bipolar, as I say, although it sounds from his history that he had some symptoms suggestive of that in the past. He was never formally diagnosed. Next slide, please. So I met this gentleman about 5 years ago when he came to the nursing home where I look after a fairly large number of patients. So still effectively bedbound and hemiplegic. And he brought with him worsening mental health problems, primarily depression, but also a tendency to be rather aggressive and demanding with the staff. And it was clear that he was very frustrated by his disability and the fact that he could no longer live at home. And this was further compounded by his lack of insight into the implications of his disability and the difficulties that would have existed were he to be cared for in the community, which he still asks about. And I often have to have conversations with him about why he cannot be managed at home even now. So that's a particular challenge for him. Next slide, please. So in the recent months, in the last, say, 3 to 4 months, his situation has become more difficult. He's become increasingly manipulative towards the nursing staff. On occasion, he has telephoned his wife from his room, and with his wife on the phone, he's then pressed the buzzer and has timed how long it takes for the nurses to respond to his call. Not when he has a particular need to call the nurses, but it's his way of testing whether he's being looked after properly. And as you can imagine, that doesn't go down very well with the nursing staff. He's also been observed to be somewhat disinhibited and sometimes inappropriate, particularly with female staff who are providing cares for him. And there's a suggestion that this is perhaps related to his stroke. He's also made some self-harm threats, which are an interesting thing, and something that I have a question for Dr. Muir later on about self-harm and suicide in aged care. And following this pattern of behaviours, it's been noted by his treating mental health team that there is this negative countertransference among the staff, that the staff at times find him very difficult and don't necessarily fully understand perhaps what lies behind some of his behaviours. Next slide, please. So to assess him, as Dr. Muir had mentioned, the Cornell Depression Scale is useful in those with cognitive impairment, and um, this is a mixture of both his reported symptoms and also behavioural observations, which form a major part of assessing his situation. And there, in this case, as you might imagine, there's a lot of such reports. The nurses have been encouraged to make detailed reports of the behaviours that he presents, as well as observing his mood and his self-reported somatic symptoms. We've also carried out a risk assessment for him, um, which is complicated by his manipulative behaviors and his expressed intentions versus capacity. For example, he has said that he'll throw himself off the balcony in the nursing home, which he's clearly not capable of doing. But that doesn't mean that the underlying risk thoughts are not there, and dealing with those is sometimes quite challenging. Next slide, please. So his actual diagnoses, he has chronic depression, which was considered to be reasonably well treated with the sertraline that he's been on for some time. And I was pleased to see that that was endorsed in green on Dr. Muir's slides. More recently, the mental health service for older people have been involved and have diagnosed him as suffering with paranoid delusions and possibly even Othello syndrome, in that he has become somewhat obsessed by issues of his wife's infidelity. Obviously, his wife um, is at home, whereas he's in the nursing home, and he will phone her and check up on her and has become suspicious about her behaviors if he can't get hold of her. He's also been diagnosed with borderline personality disorder, which fits with the pattern of behaviors that he's been displaying. And this has all been these diagnoses have been made by the visiting mental health team, including psychiatrists who've assessed him several times in the past few months, and whose input has been extremely helpful in managing this gentleman. Next slide, please. So the challenges in this situation, he has quite a complex and difficult presentation. He has challenging behaviors coupled with a lack of insight on his part, as he still expresses a wish to return home, despite that not being possible. Providing consistent approach to him is difficult, with staffing turnover in the nursing home and sometimes the staff shortages. We have educated the staff about how to handle him, but that's not always possible if the same staff are not there from one week to the next. Um, what has been very helpful is we have had regular psychiatric team support. He's had psychiatrist assessments and advice on treatment, and regular input from the psychologist, which has been helpful, although sometimes he refuses the latter. But on a good day, he will have a good chat with the psychologist and will derive some benefit from that. Next slide, please. So the treatment in his case, the staff and I and management in the home have made it a priority to have very good and clear communication with him and with his family, so that there's a clear understanding of the nature of his problems and how they might present and how to handle those. And particularly education for the staff, pointing out that if his behaviors are difficult, it may well be because he's got some frontal lobe or disinhibition issues as a result of his stroke, and he's not just being difficult. The staff generally are pretty good at their behavioral strategies, diversion, distraction, that sort of thing. And certainly on a lot of occasions, his behaviors can be quite well deflected using this. He has had regular psychologist support, which has been helpful. And he's also on medication. He's been on the sertraline a long time, as I've mentioned. And more recently, the psychiatrist has recommended that we give him some risperidone, which he's only on a low dose, and obviously there are risks associated with that, but it has taken the edge off some of his more paranoid and aggressive behaviors. And more recently, we are going to be up titrating his valproate, which is on already for his seizures, in the hope that it might give him a bit more stability in his mood. Next slide, please. So I'll just skate over this because this has been covered already by Dr. Muir and more comprehensively. But in his case, a lot of these factors have contributed to this patient's depression. But the factors there, the loss of independence, the social isolation, which has been particularly bad in the last 12 months. A lot of my nursing home residents have greatly missed the contact with their family. Thankfully, things are starting to return to normal, but that remains a challenge. The adjustment to institutional life and the inability to maintain external friendships and social networks, and the significant impact of comorbidities, as has already been discussed. And in some patients as well, the knowledge that they are approaching their end of life can contribute to this. Next one, please. Differential diagnosis, again, it's been comprehensively covered by Dr. Muir, but these are the sorts of things that we factor into our discussion as to whether or not somebody's depressed. We'll skate over that to the next one, please. Oh, there we go. We're at the end. So does anybody have any questions from that? So I can see one question's come here. Patients in general practice who don't have severe dementia, would you recommend GPs use the hospital anxiety and depression scale or the geriatric depression scale? Personally, I don't have a particular choice between the two. I don't know if Dr. Muir might have a response to that, if that's possible. Maybe not. Oh, sorry.
Okay, I think mic on?
Sorry. The question was, for patients in general practice who don't have severe dementia, is there a reason to choose the hospital anxiety and depression scale or the geriatric depression scale, or indeed any of the others would be better in that situation?
No, one of those two would probably be the best. I guess the benefit of the hospital anxiety and depression scale is that it does focus more heavily on anxiety symptoms, which may be helpful in making the diagnosis. The geriatric depression scale is one we're more used to and certainly more familiar with. However, I think either would be appropriate in a non-demented patient. Okay.
Thank you. So I don't think there are any other questions with particular relevance to that presentation. So with an eye on the time, we'll press on and I will hand over to Dr. Freed for her presentation. Thank you very much.
Thank you very much. Yeah, thanks for the help there with the technology. I always need help. Where's the flicker got to, please? Thank you. Yeah, thanks very much for the opportunity to talk about this with depression in the elderly. My case is a community-based person. She's a 75-year-old lady, Mrs. D, and this was the first time that I'd met her. She was accompanied by her daughter because the daughter wasn't confident that the mother would tell me the whole story. She was presenting with an 8-week history of no energy, depression, reduced appetite and weight loss, initial insomnia and anhedonia, and she was struggling to function. She was usually the vivacious life of the party and was not participating in any social activities at all now. There was no history of past mental health problems, and she was the wife of an Australian Defence Force GP. There'd been multiple recent major stresses, and this is one of the stress scales, and I found this quite interesting. With this lady, her husband had just been diagnosed with metastatic prostate cancer. They'd moved up from Wagga 4 years ago, and the house that they're currently living in has just been sold, and they've bought another one and are about to move. So she's dealing with all of those issues. With this particular rating scale, she doesn't actually score that highly, but I would consider that they're major issues. It's a major load of stress for anyone to deal with. When I examined her, I found that there was no evidence of any cognitive impairment, and she was generally well. She was taking meloxicam for her knees. There was nothing to find when I examined her. With her mini mental state examination, she was well presented, no animation at all, and was avoiding eye contact a lot of the time. She was weeping at times. There was no abnormal thoughts. She wanted to go to sleep and not awake, but there was no active plans of self-harm. This is the Geriatric Depression Scale that's been spoken about, and you can see that this lady scores fairly highly on it. The Geriatric Depression Scale, which is on Health Pathways at the moment, doesn't actually have their scoring system on it, and I've forwarded this version of it to Health Pathways so they can get the updated version on there for us. So the diagnosis with her was depression, probably reactive, and the anti-inflammatory could be contributing, but we also needed to exclude a medical cause. I had a brief discussion with Mrs. D and her daughter at this stage about, the classic, what is depression? Fortunately, as a new patient, she'd been booked in as a long consultation with me, but this was still a hell of a lot to cover with someone that I didn't know, as I'm sure we can all relate to. The plan at this stage was the blood tests that I've written down there. To stop the meloxicam, and for the knee pain use paracetamol, rubs and knee guards, etc. As to start some lifestyle assistance and pushing her to walk for 30 minutes a day, which apparently her husband does already, so it's very likely that she'll just join him on his walks. I was very fortunate that she'd be able to access the Employee Assistance Program through the Australian Defence Force to see a psychologist, because in my neck of the woods it's almost impossible to organise for someone to see a psychologist, which makes management very difficult. For Mrs. D, sleep was a major issue. Her husband has some temazepam at home, so I thought it was reasonable that she took one at night as an absolute maximum, but was very stressed that this was only going to be a short-term approach, and I was going to catch up with her in a week. The following week, there was no change at all in her mood or her functionality, though she was sleeping. She was walking daily and had seen a psychologist once. And interestingly, the blood test showed hypothyroidism. So this is something that Petra alluded to. Should hypothyroidism be treated and then medication for depression be considered once the person's euthyroid? The decision was to use both the thyroid replacement and an antidepressant. The rationale being that it can take 6 months for treatment to become effective for hypothyroidism, even though the thyroid function tests may indicate that they're euthyroid. Mrs. D was experiencing major life stresses independent of hypothyroidism, and those in themselves could be the cause of the depression. Also, she was barely able to function at the moment. There was also pressure from the family to use medication. So the management at this stage was mirtazapine and just weaning her on to 15 milligrams at night, and initially asking the husband to manage medication. I said that she could continue to take the temazepam for 1 more week only, and she was starting on thyroxine 50 mics a day. Provided more education materials for the patient and the family about depression, and these are some of the websites. This is from Health Pathways, which are particularly for the older folk. Also encourage the patient at this stage to start having more social time with friends. When I saw her 3 weeks later, there was some improvement, and fortunately no side effects with the medication. There was some weight gain, but she was still below what her weight was prior to the depression onset. Insomnia had settled completely, and she was no longer taking temazepam. She was starting to have some social activity and enjoying it, and was finding seeing a psychologist particularly helpful as regards how she was finding her husband's serious illness. When I saw her again 6 weeks after she started medication, her thyroid functions were normal and she was feeling like her normal self again, and the family agreed. Her weight was still less than prior to the depression, and she needed a mental health care plan so she could continue having subsidised visits with the same psychologist. We decided to have a catch-up every 6 to 8 weeks, and at 6 months repeat the thyroid functions and consider stopping the mirtazapine at that stage. The reason I thought it was reasonable to stop the mirtazapine at that stage was that it was very likely that her thyroid function clinically would have returned to normal, and so it could well be that the no longer needs, and if that was a major cause of the depression, then she may no longer need the mirtazapine, but she may have to restart that if it's, things aren't working out. And yep, thank you very much. That's it.
Thank you very much, Robin. A timely reminder of the intersection between mental health and physical problems as well. So there's a couple of questions lined up, but I think we're probably better to leave those to the end. So just because I'm not sure who would be best positioned to answer those. So rather than go backwards and forwards now, I think probably best that we press on. And therefore, I would like to hand over to Sandra Fitzgerald, please, who is going to talk us through the health pathways as they relate to this subject. Thank you.
Charles, and thank you James and Robin and Petra for those fabulous presentations and for those case studies, and I'm sure Petra will have some things to say about those case studies and hopefully keep those questions coming in so that we can have a little bit of discussion around those. And thank you very much for this opportunity to just give a shout out for health pathways, and thank you Robin for your reference to them during your presentation. I'm Sandra Fitzgerald and I'm one of the clinical editors with Hunter New England Health Pathways. And I am going to give you just a very brief overview of what Health Pathways is all about, and many apologies to all of you who are very familiar with Health Pathways and use them regularly, as Robin does. I don't know about you, James, but I know that Robin is a frequent user and sends lots of very helpful feedback for us that helps to inform and improve our pathways. But just for those of you who aren't as familiar with Health Pathways, it's based on a highly successful model of collaboration that was developed in New Zealand by a group of people called the Canterbury Initiative. And it's been around since 2006 over in New Zealand, and in Hunter New England since 2012, and the Central Coast since 2013. And at first sight, Health Pathways looks merely like another set of online guidelines for treatment and management of clinical conditions and a set of accompanying referral pages. And that's what I'm going to be showing you a little bit of today. But the main difference is that at its core, Health Pathways has provided our health system with a way of working together to best manage our collective patients and effectively implement system change. So when we're developing individual pathways or sets of pathways, the process we've adopted allows clinicians across the primary and acute sectors to develop relationships, openly discuss issues and strategise solutions that make best use of specialised and scarce resources, and to innovate change to improve patient access to care. And then Health Pathways becomes the key system enabler that allows Hunter New England Health, the system, to evolve and adapt rapidly, and the online portal that you see as GPs becomes the communication channel and repository of the information for clinicians. So just as a first starting point, I've given you the login details. On the left-hand side, we've got Hunter New England, and on the right-hand side, we've got Central Coast. The top left is the login, it's the URL for Hunter New England Health Pathways, and then the login details, because it is password protected and it's for clinicians only. And on the bottom part of the screen, we've got the patient info URLs for the Hunter, New England and Central Coast sites respectively. They are not password protected, so you are welcome to give those URLs to any of your patients, and you may actually find it useful to have stickers and cards. So these patient information cards you can get from your primary care, what's PCIO? Primary care improvement officers through your PHN. We are the PHN, through the PHN. And these are the stickers that have the health pathways URLs and login details that you can put on your phones and your tablets and on the bottom of your computers. And I'll talk a little bit more about patient info in just a minute. We have got quite a range of older persons' health clinical pathways. The one I'm going to be showing you tonight is the depression in older people one, but I noticed that Petra talked about elder abuse, and we do have a very good elder abuse pathway. We're also in the process of developing a social isolation and loneliness pathway, which I'm pleased to announce is a world first across the International Health Pathways community. And that was in response to a request from the lovely Jane Gray. And you know, it's obviously it's a growing problem, and I think it's been in the spotlight a lot recently, so I think it's well timed that we've got that pathway ready, and it's about to go live, and we will certainly link to it from the older person's depression pathway. And we've also got another one I wanted to highlight is the bereavement pathway. So on the older person's tab on health pathways, you'll see those ones you see on the screen for Central Coast and Hunter, New England, but I also encourage you to have a look at the mental health pathways and some of the other pathways like bereavement, just to see if there's something there of interest. And really the best way to do it is to just give yourself 15 or 20 minutes, if you're not familiar with health pathways, to just have a little bit of a look around to see what's on there. Or if you would prefer, we are always happy to come out to your practices and either show you around individually or as a group in one of your group meetings. Accompanying all our clinical pathways are a set of fairly robust referral pages, and across both the Central Coast and Hunter, New England sites we've got quite a range. I've just selected out some there that might be relevant to tonight's discussion across the mental health and older persons health referral sections. But yeah, have a look around. And I'm just going to quickly show you now a few highlights of the Hunter, New England depression in older people pathway. And please note this is currently under review, so in the next couple of months this will probably change quite significantly as I take away the information that we've shared tonight. And also all our pathways, once they're up on the live site, undergo review 1 year after going live and then every 3 years. So that's why this one is now ready for review. And as part of the review process, we send it out for independent GP review, independent pharmacy review, and then we get subject matter experts, who are people like Petra, to review the final product before it goes back up on the live site. So this follows the classic layout. So on the screen here you can see background and assessment, and on the next screen you'll see the management and referral sections. Just at the top of the page there you can see two icons. One's an Aboriginal and Torres Strait Islander icon, and one's a multicultural icon. When you see that at the top of the page, you know that there's information in the pathway that specifically relates to those two populations. And if you flick down the pathway, you can see there the relevant bits where you'll find multicultural and Aboriginal and Torres Strait Islander information. And I also, so you can see here now the management and referral sections of this pathway. I also want to highlight down the bottom of each pathway there's a section for health professionals, and that's where we house the latest clinical resources, guidelines, robust journal articles and things like that you might find if you want to read up a little bit more on a particular condition. And then we've got the for patients section that Robin has already alluded to, which I'll talk a bit more about in a minute. Accompanying this page on both the Central Coast and Hunter, New England sites is an antidepressant for older people, which again is also under review, and it follows that same assessment management set out. And it's just got some more detailed information on antidepressants for older people and the nuances of prescribing in this population, but that will also have some changes in the very near future. This is the management section of that pathway, and again down the bottom that for patients section. Now everything in that for patients section has been reviewed by a pharmacist or GP clinical editor to be clinically correct and aligned with the pathway content, and then it goes through a second filter which is a readability filter. So everything that you see on health pathways patient info has got about a grade 6 readability level, which is what we've determined to be the level that the majority of the patient population will be able to read and understand. And if it doesn't pass that readability filter, we don't put it on health pathways. And everything that's in that section, we have taken out and put on the sister site, which is called Patient Info, which is the non-password protected site. So if you wanted to take one of these cards and give it to the patient with, you know, the topic, so heart failure, depression, whatever, they can go home, look up that information and have a good read, and you know that what they're reading is reliable, clinically appropriate and readable. So the very last thing I want to say is that on every single page of Health Pathways there is a send feedback button. On the Central Coast it's up here in the top right on every page, and on the Hunter New England site, if you're using the mobile friendly site, it's in the bottom right hand corner of every page. And can I please encourage you to send feedback, because we respond, we check it every day, and we really do rely on you as our eyes and ears on the ground who are using the pathways to spot errors, to let us know if something doesn't make sense, to let us know if we've missed something, or even if you just want to say, good job, Health Pathways, that was great. We love that feedback too. And thank you very much for your time tonight. And keep the questions coming.
Thank you very much, Sandra. Yes, certainly the Health Pathways site I find very helpful. I look at it a lot, and I'm interested to hear about the patient info question. I actually have a question for Sandra about that, but I don't know whether we're going to open this up now to our wider panel. Indeed, we are. There's everyone. Okay. So if I could just have a follow-up question there to Sandra. The patient info sections, those little cards to hand out to patients, that's great. I can imagine some perhaps of our elderly patients might struggle with the tech know-how to access that, and I know that actually some of my patients just don't have access to the internet. Is that something that's readily printable in that format on those pages? Is it something we could print and give to the patients, or is it a bit too, I don't know how many pages, or whether it's already in a sort of succinct form?
Most of the resources will be printable, because most of them aren't that long because they don't pass the readability filter. And we have just recently started putting in square brackets printable next to printable resources. But we've only just started that, so you can imagine across 300, 400 pathways, the retrofitting of that is taking some time, and we're doing it as we review pathways. But certainly the vast majority, I would suggest, would be readable, would be printable.
Okay, that's great, because there's certainly probably a relatively small cohort that would prefer that, or who have difficulties actually accessing the internet. So that's great to hear. Thank you very much.
And that's the feedback we love the most. Is if there's a patient information resource that you normally use that's not on patient info, please let us know, because we're always interested to hear what GPs like to use.
Sure. Well, I've done some of that pathway review process that you talk about, and generally I find the pages are very high quality and have everything that we need there. So I use it a lot, and I think it's great. So thank you for that. A couple of questions. One actually came from Dr. Freed earlier, which I think is probably a question best for Petra, which was a question is, when deciding which antidepressant to use in an elderly person, is it useful to find out whether family members have responded to a particular drug or not responded to a particular drug, which I guess is genetic factors in medication suitability? Is that something that's clinically useful?
Well, that's a very interesting question. Personalised medicine is certainly something that we are working towards, but simply going with a single family member's use is probably an oversimplification. I don't think that will necessarily give us a finely detailed enough set of information or set of data to make a decision about that individual person's response. Interestingly, though, people can be very keen to try something that someone else in the family has tried. So one of the possible benefits, if you think it's a reasonable medication to try in any case, is that person might have better medication adherence, because they've already got a degree of trust that someone else has taken it, that they've benefited from it. And I hear people asking that question of me sometimes: can I try what, Auntie so-and-so tried or Mum tried? Because they seem to think that might be good for them. The reality is that genetic testing for personalised medicine is available. It can be expensive. It doesn't give us everything we need to know yet, but it is at least in principle, something that we should be working towards. And internationally, they're certainly talking about this as an increasing option for people.
What else do you think we are?
Oh, well, I've had reports from some of the tests that have been done locally, and unfortunately the data set is quite dense and busy, and usually there are a lot of caveats. So it says, look, the indicators are such and such and such and such, but there's no real degree of certainty in any of it. So not super close, I would say at this stage, but we're moving in the direction of. So, you know, watch this space over the next 5 to 10 years.
Yeah.
Thank you. Just as a follow-up on that, actually, is there any reason to assume or indeed not assume whether somebody's response to a given antidepressant is likely to be consistent over their life or over a longer period? So a drug that somebody's taken 20 years earlier and suited them well, is it reasonable that that's likely to suit them again, or is there a particular change in how people respond to medications over time?
Well, there are changes that might affect your choice of medications over time. They may not necessarily be the pharmacodynamic changes, the response at the receptor neurotransmitter end. They may be pharmacokinetic changes which make it less viable to use certain medications that once they could use when they were younger. And I'm sometimes talking to patients about the fact that, you know, they've been on a certain medication for quite a while. They want to keep taking it, or they feel it's something they'd like to try again because they tried it before. As they get older, they may not be suitable. Amitriptyline or the tricyclics are a good example. Aging brings changes that makes it difficult to support some medications now, which were once quite reasonable. The ability to decide whether they should be able to respond well, if it is a suitable medication, is a little bit coloured by the fact that you can't always get good data about what they used, for how long they used it, the dosage, titration. All of that stuff is important information. Patients don't tend to retain those level of details for months, let alone years or decades. So it can make that a difficult decision.
Yes, thank you.
I don't have all the information about this, but I had one patient who was on an antidepressant which worked very well. She probably shouldn't have come off it, but did. And then several years later, when she was going through menopause, she floundered again, tried the original antidepressant, which didn't work at all. And then, as I said, I can't remember the details, she went on to something else which was very effective. But it was very interesting that was that menopausal change in what was appropriate for her. And I must say I haven't done any research about it since then.
Yeah, and there's a certain amount of changes in neuroreceptor density that also could have a part to play, more in the negative side of things. We tend to see this a bit, that people don't respond as well, rather than that there's a good reason to expect that they would respond well. So that's an example that I'm familiar with too.
Yeah.
I've seen that.
Thank you. One other question, which actually is one of mine, and I'd be interested in the panel's views on the issue of self-harm and suicide in the aged care setting. Obviously, in the community, we tend to be fairly well set up with urgent response teams to try and manage when at-risk situations are identified in the community. But in the aged care setting, I haven't a lot of experience of it myself, but I guess things are slightly different because there's this sort of perception that it's already a sheltered and supervised environment to some degree, and maybe the risk assessment is not considered quite so acute. I just wondered if anybody in the panel had any experience of that.
Well, I'm happy to answer that. I think it's important not to underestimate the risk even in aged care. Yes, there is supposedly a greater level of supervision, but there are also long periods of time when people are not supervised. And, you know, there are access to means and methods that are still potentially lethal, and we do tend to see people trying to hang themselves or strangle themselves, ligature around the neck, tied to the bed. Some people have collected medications because it's not that well monitored in some aged care facilities, so you can't assume that they're going to be completely free of risk. The issue you mentioned about the balcony is also a difficult one. There's a number of nursing homes that I've visited over the years where there has been access to balconies, and that can be very problematic. And because it's a communal area, it's not as simple as saying, okay, we're going to keep that door locked all the time either. So I think a very thorough risk assessment is important. And if you're concerned about that in an aged care facility, I'd be making a referral to the local community mental health team, because we have a multidisciplinary team that can go into the aged care facility, assess the patient, talk to the staff, help the staff do a risk assessment, and also develop a safety plan. So the safety plan is the other side of the risk assessment, and that's a really essential component when you identify someone at risk in an aged care facility. And as I said before, there's also risk of self-neglect. You know, they're just not complying with measures of care. That might also put them at risk, and they may not want to use their walking frame, so they're at risk of falling, which again is a de facto way of, you know, harming oneself, and can be potentially fatal if they fracture their neck of femur. So, you know, there are ways in which people can hurt themselves, and I think the safety plan is really important.
Yeah, so as you say, deliberately putting oneself at risk is another manifestation of that. And going back to what you said about the mental health team, that's what happened in the case that I presented. They did come out and do a risk assessment and so on, and we were very well supported in managing that gentleman in that situation. So there's no other questions come through on Slido. I don't know if anybody else has any questions or comments they would like to make from the panel.
Just as far as benzos go, when you've got someone which you're looking at short-term usage while you're waiting for an antidepressant to start to be active, what's your perspective on that, Petra?
Right. Well, my perspective is probably coloured by the fact that I see a lot of the patients where that doesn't work out so well, where that goes wrong. And so you know your patient best, but if there are any personality factors where you think dependence may be an issue, then I would avoid starting a benzodiazepine because it's amazing how well they can feel as a result of that initial start, and then it becomes difficult to wean them off it, despite all the prior education you give. Plus, you have the added difficulty that it will counteract the benefits of the antidepressant to some degree. So there's also very important risks in terms of cognitive changes and risk of falling that we have to bear in mind, even with those with a short half-life, which I know you chose temazepam, which has a short half-life, and if you have to use something short-term, that's the preferred option, rather than, you know, alprazolam, lorazepam, diazepam. So I guess, yeah, that's my concern in terms of benzodiazepines.
Oh, thank you.
Yeah, I think an interesting corollary to that is that, Robin, if you have some look after some people in nursing homes as well, I think there's quite often quite a lot of pressure from staff to medicate people if they're awake overnight or if they have disruptive behaviours overnight. That's a significant problem, and obviously it's a very hot topic currently into overuse of sedating and psychotropic medications in nursing homes. But it's something we haven't really spoken about, but I guess it ties into your comments about the dangers associated with those and the difficulties in accessing alternative treatments for those, so behavioural things and regular psychology support. You mentioned that access is difficult. I think that's a pretty universal problem, isn't it? Which we all deal with both in the community and in aged care. Okay. Anybody have anything else they wish to? Yeah, sure.
I've got one too.
Sorry. I picked up on the meloxicam issue, and I think that's an interesting one, particularly in terms of non-steroidal anti-inflammatory drugs. And if you were to start an SSRI in that person, I'd be deprescribing the non-steroidal because it's often overlooked, but there's a significant increased risk of bleeding disorders. If you can't get by without a non-steroidal for whatever reason, then the advice is to consider a proton pump inhibitor to protect at least from gastrointestinal bleeding. Doesn't alter the risk of cerebrovascular bleeding, but it certainly can at least modify that.
Also choose one of the lesser gastrotoxic NSAIDs.
Yeah, meloxicam is certainly pretty potent and high rate of side effects.
Yeah, I think
probably preferred rather than oral.
Yes. Sorry, please go ahead.
Thank you. With Dementia Australia, which was DBMAS, that's an organisation which goes into aged care to help with problematic older folk with behavioural issues, usually related to dementia, but is it available in the community as well?
Technically it is. I guess, though, the need in aged care has been fairly great, and I'm just not aware at the moment of how much presence they have in the community. I certainly seem to get requests mainly from aged care facilities, and I guess the community living people with dementia, they also have needs, but perhaps have behavioural disturbance to a degree that allows them to function a little better until they get to that point where people are saying they're outstripping the service capacity. So I remember they used to, when they were DBMAS, we had community supports and services, but I'm not sure how that's progressing now. I'm sorry.
My understanding is that they are available for the community, but maybe that the awareness isn't as high that they are available.
And that's probably right, because in an aged care facility, you've got the nursing home staff who are there raising their hands and saying, we need help, whereas family members at home may not know that.
Yeah, that's certainly my experience as well. That's certainly my experience, that it's primarily in nursing homes that team responds. And I guess that probably reflects that the majority of people who need their input are perhaps at the stage where they're likely to be in residential care anyway. In the community, they'd have different supports and probably down the less severe end of the spectrum. Right. No other questions have come in. If nobody else has anything, I will plan to hand back to Charles. And thank you very much to our panel for their presentations and contributions this evening. And I'll hand you back to Charles to close the session. Thank you very much.
Wonderful, thank you, James. And yeah, I'd like to take this opportunity to give a very big thanks to all of our speakers tonight. So thank you, James, for both chairing and presenting. You've done a great job. And also for joining us here in the room, we've got Petra, Robin and Sandra. We really appreciate you taking time out of your busy schedules and joining us as well. That was fantastic. So before we finish up, I just want to draw your attention to the evaluation survey in Slido. So the tab's just on the right-hand side, so it's under the polls tab. If you could just take literally 1 minute to fill that one out before you log off, we'd really appreciate your feedback. We're always looking to try and improve on how we deliver our education to you. So this is part of our Chrysalis Wellbeing series. So the next session, session 4, is being held on Wednesday the 12th of May. It'll also be at a similar time in the evening. And the topic for this session is supporting young transgender people. We haven't advertised that one just yet, but just keep an eye out because registrations will open very soon. All right, thanks again for joining us, and we hope you all have a safe and enjoyable evening. Good night.
Scream. We don't wanna grow